In the cath lab, an ASD is closed through a minimally invasive approach. First, your child will go to sleep, won't feel any pain, won't remember anything from the procedure. Then when they're asleep, we'll put special catheters through the top of their leg, and we'll thread those catheters up through the veins of the body to the heart, where we can take pictures and pressure measurements, but for the ASD, we focus primarily on finding the ASD, figuring out exactly how large it is, and then using x-rays and then a transesophageal echocardiogram, which is an ultrasound through the swallowing tube, the esophagus, to guide placement of a device across the ASD. The device has two sides. One side sits on one side of the hole and the other on the other side of the hole, and when it comes together, it closes the hole. The cath lab procedure usually takes under an hour. For more complicated ASDs, it can take a little bit longer, but generally the procedure is under 1 hour. It's a little bit longer between when you say bye to your child and get to see your child again because they have to go to sleep. And after the procedure is done, we take all the catheters out of the body and they wake up with a Band-Aid on their leg. And that process can take up to a total of 2 hours or so. After the catheterization is completed, your child has to remain in bed for somewhere between 2 to 4 hours before they can stand up and walk around. And generally they spend 1 night in the hospital to make sure there are no issues with the ASD closure device or with the site where we entered the leg. And if everything looks okay the next morning, we can let your child go home and get back to pretty normal activity within a few days.
So there's several options if your child has an atrial septal defect and is not a candidate for cardiac catheterization and closure via device. Usually this is because what we call the rims, or the tissue around the atrial level defect, is insufficient. It doesn't give enough room to land the device. You're often referred to surgery then, and historically surgery has been a full sternotomy. And then over the last number of years, it's become a so-called minimal sternotomy where we do a half a sternotomy. And now we're approaching these through the side or under the armpit where we can make a very small incision, which gives us really excellent exposure to close these defects. And that approach affords us several advantages. We think it's less painful, there's less hospital stay, cosmetically it's better, it's hidden, you don't have a large scar on the center of the chest. So there are a number of reasons we think this approach is now better for patients with ASD and other lesions as well. One might approach an ASD through a sternotomy if there are other additional lesions in addition to the ASD that need to be addressed that cannot necessarily be approached through a thoracotomy.
After a minimally invasive ASD repair, either through a thoracotomy or a small lower sternotomy incision, the patients go through a perioperative program that's called the Enhanced Recovery After Cardiac Surgery. They'll have the operation and will get extubated in the operating room by our anesthesia team. From then on, they'll move to the ICU where they'll have ongoing monitoring and pain management. They'll often be out of bed on the day of surgery and walking around the ICU the next morning. Their tubes will get removed overnight and early in the morning so that we can minimize their pain and maximize their ability to ambulate and move around. After an ASD repair through a minimally invasive approach, patients can leave as early as 2 days after surgery or 3 days after surgery.